Great to see so many of you have joined today. So my name is Michael Anderson. So I'm a clinical lecturer based at the University of Manchester and the London School of Economics. I'm also an advisor to the European Observatory on Health Systems and Policies on Antimicrobial Resistance policy. So today we're really pleased to be launching our brief, the Socioeconomic Drivers and Impacts of Antimicrobial Resistance. This is shedding light on a topic that's crucial to adapting effective and sustainable policies to tackle antimicrobial resistance. And for too long, we focused on the biomedical model of antimicrobial resistance. And increasingly now there's acknowledgement that we need to integrate our thinking around social determinants of health and antimicrobial resistance to make sure that we can protect the vulnerable in society and adapt our policies to address health inequalities. And we have a fantastic panel today, which will be talking you through some of the findings of the brief, but they'll also be reflecting on some of their own work in this area. And then this will be followed by an opportunity for you to ask questions in the chat, and there'll be general discussion on how we can incorporate the socioeconomic drivers and impacts of AMR into policy. So we're going to start with Gunnar Ljungqvist from Georgetown University. So he will give you a summary of the main findings of the policy brief. And then in the panel, we're going to have Esmita Charani from the University of Cape Town, South Africa. And then we will have Anthony McDonnell from the Centre of Global Development. Then we will have Victoria Sant from University of Bielefeld, Germany. And then we will finish with Danilo Verwong from the WHO Euro office. So with that, I'm going to hand it over to Gunnar, who will talk us through some of the main findings of the policy brief.
Thank you very much for that introduction. Let me just share my screen. This works. Excellent. All right. So I am here today, as Michael said, to give everyone an overview of our policy brief. I'd like to start off by thanking the European Observatory for inviting me to be involved in the project. I'd also like to express my gratitude to the World Economic Forum, who received support from Novo Nordisk Foundation for providing funding for this project. So I'm going to try to keep this presentation very brief and succinct, but for any further detail, I would welcome everyone to review the policy brief in full. So why are we doing this brief? Why does this matter? Well, our understanding of AMR historically comes from more of a biomedical model, and these biomedical models tended historically to be more organism-specific or organ-specific or sector-specific. But there's an increasing understanding in the community that social and economic factors underlie and drive AMR in comparable ways across different sectors, across different organs, and across different organisms. Furthermore, we know that AMR has a significant social and economic impact on society, but those impacts are not uniformly spread across society. So in this manner, AMR is both being driven by socioeconomic disparities while also potentially reinforcing those same disparities. So if we are able to identify and characterize these mechanisms behind this negative feedback loop, we could use this data to specify high-yield targets to help our policymakers maximize impact across sectors. So in this policy brief, we're going to answer the following questions. How do socioeconomic factors drive AMR? In what ways does AMR impact socioeconomic factors? And how can we design AMR policy to ensure that socioeconomic considerations are being addressed and embedded into them? So to approach this, we designed a two-part methodology. On the one hand, we performed a literature review. We did an umbrella review of systematic reviews, which meant that we looked at research articles that had in of themselves addressed a larger pool of data, and we did this in order to try to capture as wide a data pool as possible. We chose to focus on quantitative evidence of drivers, we specifically looked at research that had in some way quantified an association or a correlation between a socioeconomic dimension and either antimicrobial resistance or antibiotic usage. We specifically chose to exclude clinical factors. This was because the literature on this is already very well established, and we wanted to try to highlight the dimension that was beyond the biomedical factors, to try to really hone in on the socioeconomic side of things. We also conducted some stakeholder reviews. So we used purposive sampling and snowballing to identify experts in the field who were representative of both high-income and low-middle-income countries. And we had everyone from academics to policymakers involved. We ended up with 13 semi-structured interviews in total. So, in doing the above, we identified 10 socioeconomic themes. This list, I should say, is not exhaustive, but rather it reflects the most salient factors that were identified both by the literature review and by the experts in the field. So, going through these briefly, gender reflects the increased rate at which women typically tended to be exposed to AMR, either through occupational exposure or through higher rates of antibiotic prescription. Living conditions relates to the higher rates of AMR transmission carried by overcrowded or hyperdense environments, or by the lack of water and sanitation infrastructure. Educational level describes the patterns in which health behaviors associated with lower or higher educational attainment varied. And these tended to follow different patterns across the world. Access to healthcare reflects the increased risk carried by patients when facing obstacles to appropriate healthcare, resulting in practices such as inappropriate self-medication, but also prolonged infections due to antibiotic shortages leading to inappropriately untreated infections, as well as suboptimal antibiotic choices due to supply chain issues. Poor governance refers to the challenges in enacting AMR policies in situations of political instability or limited rule of law. Human mobility encompasses recreational travel, medical tourism, and forcible displacement, and the global transmission of organisms that carries. The theme of conflict encompasses not only forcibly displaced populations, but also infrastructure breakdown, environmental contamination, supply chain disruptions, and the living conditions that affected populations are subjected to. Climate change describes the changing environment relating to climate, obviously, but this manifests itself through higher temperatures driving faster bacterial proliferation rates in the environment, as well as the increasing risk of extreme weather events and the disruption that these causes. Agriculture refers to the broader antibiotic practices driven by food demand and by the accompanying high rates of animal to human or animal to environment AMR transmission. And finally, pollution describes the contamination of the environment with healthcare and pharmaceutical waste, which introduces antibiotics and antibiotic genes into the environment, but also heavy metals, airborne particulate material, which generates evolutionary pressure on the environment, as well as plastic and water bodies, which provides an avenue for long distance transmission. So those are the drivers, but what about the impacts? Well, the evidence on socioeconomic impacts can be summarized into three layers: individuals, health systems, and societies. These tended to be one of two things, either health impact or economic impact. At least that's what the literature gives us. And health impacts can be things such as mortality or morbidity, and economic impacts can encompass things such as the cost of healthcare or production losses. Now, the point to emphasize here really is the fact that these impacts are not uniformly spread across society. For example, GDP losses are more harshly felt by LMICs. Productivity losses are more likely to be felt by families relying on informal revenues. So whether it's LMIC or household revenue, the commonality across the impacts is that they tend to go and be felt by the populations that are most vulnerable, and whatever vulnerability looks like in that context. So, what does this mean for AMR policy as we know it? Well, we identified 4 overarching principles. Firstly, we need to identify effective governance. We need to make sure that policies are transparent, they're sustainable, they're coordinated, and they're accountable. We need effective leadership in order to enact all of this. Secondly, we need people-centeredness. The policies vary according to, or the need and the impact varies according to context. So we need, when we're drafting policies, we need to make sure that we're framing them around individual contexts, because those will change from place to place. Thirdly, we need to make sure that we approach this from a multi-sectoral perspective. We need to move away from the silo culture of the past. The driving forces that dictate and drive AMR they move through different sectors and they articulate between different sectors. So we need multidisciplinary input and we need multidisciplinary buy-in. So we must approach it from a holistic perspective. And fourthly and finally, we must encourage evidence building. So we must understand better the socioeconomic forces that drive AMR. We must strive to generate data. We must strive to generate good quality data. We must disseminate that data. We must evaluate our interventions and monitor those impacts on society. And that's it from me. I'll hand it back to Michael. Thank you.
That was great. Thank you, Gunnar, for summarizing, what's quite a complex issue in such a short period of time. So that was amazing. So what we're going to do next is we're going to start our panel discussions now. So there's going to be a spotlight presentation from each panelist where they're going to reflect on a different aspect of their own work, which relates to the socioeconomic drivers and impacts of AMR. So to begin, I'm going to hand over to Esmita Charani from the University of Cape Town, South Africa, and she's going to talk about how some of those drivers that Gunnar's highlighted, they can when they can interact with each other and exponentially increase the risk to AMR.
Thank you very much. Hello, everybody. It's a pleasure to be here and discuss the work that I contributed to in this report, but also the research we're undertaking in South Africa and India. So antimicrobial resistance is a multifaceted global health challenge, and the drivers and consequences of this challenge are socially manifested. And what this report is alluding to and is reiterating is exactly that. That often we rely on single interventions, for example, evidence-based guidelines, better diagnostics, or new antibiotic agents to come to the market, but these do not account for the structural and social determinants of health that are driving antimicrobial resistance and the threat it poses globally. So healthcare workers, patients, and their carers are vulnerable to risk of infection. And these vulnerabilities can change and shift depending on socioeconomic and sociodemographic factors, which we need to have a better understanding of. And to be able to optimize care, we have to have a collective as well as individual lens on the behaviors of populations, but also of people. So socioeconomic and cultural inequities, of course, influence health-seeking healthcare access and health-providing behaviors. And this, in turn, impacts health outcomes. And to effectively manage antimicrobial resistance, it's really important for us to be able to understand and address these inequities and their consequences. And so focusing on lower middle-income countries, a lot of our research is asking specific questions about who are those who are most affected by the threat of antimicrobial resistance? What is the burden of infection in different populations, and how does this put them at greater risk of untreatable or difficult to treat infections? How can we look at the equity or inequities in access to healthcare and disease prevention programs, for example, vaccination, water, sanitation, and hygiene in different environments and contexts? And how can we better understand these conditions that promote the emergence of antimicrobial resistance including interrupted, inadequate, and inappropriate treatment, which can make people be dependent on antibiotics through informal routes without the need of a prescription. So these are some of the challenges that we face. And what is really important to understand is that different groups in society face greater or different risks of exposure to antimicrobial resistance, or more challenges in accessing, providing, and using and benefiting the information, services, and solutions that are available to tackle antimicrobial resistance, including infection prevention and control. And whilst, for example, antibiotic stewardship may have dividends and high return in one setting, that may not be the case in another setting. In many low and middle income countries, it is access to vaccination, water, hygiene and sanitation, and infection prevention and control practices that need to be robust and need to be improved before we think about antibiotic stewardship. So we have to contextualize solutions. And we need to study the multitude of social constructs, hierarchies, and inequalities that are creating axes of power that influence behaviors. So a lot of my work and the work of our team has looked at power dynamics, and we have described this in the context of antibiotic prescribing behaviors in hospital settings specifically. But to have solutions to address these inequities and power inequities and dynamics is still lacking. And applying intersectional inquiry will help us to better understand how axes of power and social constructs are predictors of infection control, infection prevention and control, and antibiotic resistance related behaviors. So intersectionality, which is what we're arguing for, hinges on understanding us as human beings and how we are shaped by the interaction of different social constructs, which includes race, gender identity, class, geography, religion, migration status, caste in some cultures. And these interact with connected systems and structures of power, for example, healthcare systems, to influence health outcomes. And most of the challenges and inequalities in healthcare are in low and middle income countries, where there has been more limited research that takes an intersectional approach. And recognizing these complex interactions and dynamics will allow us to better understand social inequalities as well as their drivers, allowing us to provide better healthcare and better responses to the challenge of antibiotic resistance. And critically, it will help us to have an innovative lens to understand, through an intersectional lens, how healthcare systems are currently disempowering those less advantaged due to the circumstances that we are in, whether it's socioeconomic status or race or ethnicity or caste or gender, and how this is hindering us from seeking and providing optimized healthcare. So intersectionality is an important lens to consider as we go forward in antimicrobial resistance. Thank you very much.
So I think that one of the key messages of the policy brief is around trying to get access to the right antibiotic at the right time. So access should come hand in hand with stewardship. But one of the when people talk about access, often it's overlooked that it's important to secure equitable access globally. So what European institutions need to consider, not just how to secure equitable access to antibiotics in the European region, but also globally in LMICs as well, because it's in Europe's interest to make sure that we don't see LMICs don't become a reservoir of multi-drug resistant pathogens. So there has to be some incorporation of access agreements within incentives to secure this. So we discussed and referenced some of the great work undertaken by Anthony McDonnell at the Centre of Global Development, and I'm going to hand over to him now, so he's going to elaborate on some of this, which is highlighted in the brief.
Thank you very much for that, Michael. And can I start by saying thank you to everyone involved for this really excellent report. There's not nearly enough research done onto the social determinants of antimicrobial resistance at the moment, and hopefully this is the first of many things to dive deeper into the various experiences of different socioeconomic groups and how we can make sure that their needs are met. I'm going to talk to you about access, but I'll also touch on stewardship and innovation. And essentially, it's because we need to solve all three of these pieces to have a kind of a healthy stool, as the analogy suggests, of antibiotics, and to keep antibiotic resistance at bay. We also, as Esme pointed out, things like vaccination and WASH are crucial. but if to stop people getting resistance. But essentially, if we have access to antibiotics, but we don't protect them from stewardship, then we will lose that innovation. If we protect antibiotics from everybody from unnecessary use, then there is no value to them. And if we generate antibiotics, but they're either lost through access or held back from people who need them, then that doesn't create what society needs either. But we need to bring together these kind of three pillars to create policy that really works. And so to go to access, as Michael mentioned in his intro, there is a huge problem with lack of access to antibiotics around the world. This problem is particularly acute in low and middle income countries, but it is not universally, not universally a problem there. It is also a problem in Europe and other high income parts of the world. This causes resistance for a couple of reasons. The main one being that if you don't have access to the most effective drug, you might use a different drug. So, for example, if you've an infection that amoxicillin can treat, but there's no amoxicillin available, then clinicians are likely to move to a more protected drug and not a first-line treatment. And this will generate resistance to those drugs that we're particularly trying to protect for emergencies. And the second reason that lack of access causes resistance is that if people don't have access to a drug, then they are going to be sick for longer and they're more likely to pass that infection on to other people. And so resistance has a chance, and bacterial infections in general have a chance to spread. There are three main causes of this. The first is that most new antibiotics don't get registered in most countries. They don't even get registered in most high-income countries. And there's lots of drugs get registered in the United States, but only a handful of European countries, if any. This is particularly a problem in low and middle-income countries. Generally, drugs that are seen as very important in Europe do get registered in Europe, but many drugs that are of kind of lower order importance don't. And those are plausibly the drugs that kind of more niche groups need, and these are the type of people who get left behind. Secondly, there's a huge problem with supply chains of antibiotics, particularly for generic drugs. The margins are very, very low. And so companies do not build out very robust supply chains because they're competing on price. And this can lead to stockouts across the world. In December 2022, January 2023, there was large shortages of amoxicillin and other drugs because of greater disease burden in the world, particularly in Europe and North America. Probably also shortages in the rest of the world, but the data there is less good. And so for this reason, the Norwegians have come together with Iceland and I believe it's Sweden to come up with a procurement model that doesn't just purchase the cheapest antibiotics, but gives a reward for, or gives each tendering company a score and rewards those which are shown to have a really reliable supply chain, so that they can be assured that they will have access to the drugs when they need them. And it's also why Sweden has its own way of purchasing antibiotics with kind of a price guarantee where they promise to buy or to pay for a certain amount of antibiotics whether or not they need them, so that they are there if they do. And then finally, there are huge amounts of kind of social barriers to antibiotics. So people don't have access to a doctor, it's too far away, or certain antibiotics are only given out at tertiary healthcare facilities, but people don't have access to them. And this leads to a large amounts of loss of life in low and middle income countries. In Europe, probably there aren't very many people dying from complete lack of access to antibiotics, but there are still people who don't go to see their doctor because doctors are expensive, so they wait until their infection is quite bad, or people who stop taking a drug as soon as they start to feel better because they want to keep the tablets in case they are sick again. And all of this generates resistance and generates a less healthy population. And so we need to ease some of the barriers around sick people getting access to antibiotics. At the Centre for Global Development, we proposed a way forward to improve this, what we call a sustainable access hub. But essentially what we mean is we need somebody to sit between between manufacturers of antibiotics and procurers who can purchase the drugs in a pool procurement way and pass them on, because it often not really makes sense from a financial perspective for pharmaceutical companies to sell drugs into the poorest regions of the world, but even into middle-income countries or into small high-income countries where there's a lot of costs with supplying a drug to a region and registering it, and the margins are so small. At a European level, in my view, it makes sense for Europe to create some kind of access system to ensure that everyone has access to new drugs and to all drugs that they need. And then very quickly on stewardship, I mean, it's quite clear why stewardship is important. We need to reduce unnecessary use of antibiotics so that we don't generate resistance when we don't need them. There is often a slight tension around stewardship and access. Until we have a perfect way of telling who is in need of an antibiotic and who isn't, you're always likely to get false positives and false negative assessments from a doctor. And that will lead to people sometimes not getting an antibiotic when they need them, or too many people getting an antibiotic that they don't need. And so we need to minimize that trade-off, but we also need to be aware that kind of it is the vulnerable groups that this report talks about that often get cut out the most, and particularly rural people and people who do not know the system very well, don't know how to lobby their doctor, who get cut out if we are too strict on stewardship. And then finally, we need new drugs when resistance becomes too high. We also need drugs that meet the needs of vulnerable groups. Too often we talk about how bacterial pathogens are mostly the same, but there are different needs around, say, broad spectrum drugs, the need for oral treatments, and more research, frankly, needs to go into what are the bacterial needs of the most vulnerable groups. And European Union can play a really important role here in encouraging new antibiotics. And in making sure that those antibiotics fit the needs of all Europeans, but I would also hope of the whole world. Thank you very much.
That's great. Thank you, Anthony. So we're going to move on to Victoria Saint from the University of Bielefeld, Germany. So I'd just like to express my gratitude to Victoria, one of the co-authors of the brief, who really was fundamental in offering her perspectives and working in not just academia, but policy as well. So she's one of these very talented people that can move between those spaces effortlessly. And it's great that she's going to talk now about, so drawing upon these experiences, talk about translational policy making. So how can we take the findings from this research, from this policy brief, and integrate them into policy making?
So I wanted to complement what the other speakers have focused on by looking at one of the other areas where there is gaps, which is about the translation of evidence on socioeconomic equity and inequality dimensions of AMR into action and policy and intervention and program level. And in particular, I think the argument is often made in AMR circles that there's not enough evidence about these dimensions to be able to take action. And I think that's somewhat misleading and potentially even often used as a bit of a red herring. So I want to unpack that a little bit. So the first question is does evidence exist? And I think as this policy brief and other work shows, there is in fact a decent amount and a growing body of robust evidence demonstrating the important role that socioeconomic inequality and inequity dimensions play in exposure and vulnerability to resistant infections, in health behaviours and knowledge, and to outcomes and consequences of health issues and health service access issues. So other papers in recent years have also consolidated the evidence around gender dimensions and cultural context dimensions in different regions and globally. But there's also an increasing number of studies in national and subnational context showing these marked differences in knowledge, exposure, access, and other factors for different population groups. And where I see a key issue is that this evidence and these experts who are producing it are not at the decision-making table. So while they might be publishing their results, they're being published, for example, in sociological journals or political economy journals, which core AMR, National Action Plan workers or surveillance people might not be kind of reading. And that the nature of this evidence is also different. It's sociological, it's economic, it's potentially qualitative or more ethnographical and so forth. So one of the things that we need to do is really open up these spaces to be more interdisciplinary, to recognize a broader range of interprofessional experts, and make those people sitting, or invite those people to be sitting at the table where decisions are made, where policies and actions and interventions are designed. And that really complementing this traditional biomedical and technical and quite individualistic perspective, which is incredibly important in AMR, but complementing that with evidence that sheds a light on the sociological, cultural, and structural context and how those things are interacting. So having these people at the table, having this evidence on the table is going to be fostering this more holistic understanding, not only of the problems, but in particular of how to use this type of evidence to inform improved practice. So that's one of the things. And in this regard, for example, the World Health Organization last year released its people-centered approach to addressing AMR and human health, really aiming to move away from the traditional bugs and drugs approach. And they're now, with the support of the Fleming Fund and UK Aid, they're working on a series of practical guidance documents for NAP, National Action Plan implementers in country, on how you can strengthen gender equity and disability factors in National Action Plan work. So there is evidence and there is efforts being made to kind of translate that, but traditionally this has been a real weak point and more work in this area is needed. Secondly, there's also a huge body of work and evidence on other areas of health and other health service and social service interventions that are extremely relevant for AMR, where we have very robust and many decades of experience and expertise around equity and socioeconomic issues. We saw this very clearly during COVID, but also, for example, HIV, tuberculosis, and other areas like maternal child health and NCDs, where a lot of the progress in the last 2 decades has really come about because there's been increasing recognition of these underlying socioeconomic and equity drivers. And that includes the way in which these issues can block effective uptake of new technological interventions. So the COVID vaccine, HIV retroviral treatment, tuberculosis treatment, and so forth. So what we need to be moving towards is opening up these spaces, but also to be looking at how we can bring social innovation and marry that with new technological innovation, that interface is extremely important, and you need different people at the table to help that kind of contextualization and social innovation implementation component. And then thirdly is that there are a lot of gaps in the evidence. There's a lot of gaps. There's a lack of nuance. There's a lack of kind of cultural specificity and local context specificity around these issues, both between LMIC and HIC countries. But I think increasingly more relevant potentially is within country inequalities, both in low and middle income country, but also in high income country contexts. So this area of kind of equity dimensions and socioeconomic dimensions of AMR has traditionally been understudied and under-resourced, and there is a real need for dedicated funding, dedicated grants, and dedicated programs within M&E to be pushing forward our understanding of how this works. And that includes the kind of unequal access and impacts of intervention. So implementation research and participatory approaches with community incredibly important. Yeah, so I mean, I guess in summary, there's a lack of evidence, and that's one important issue. And I saw Claire Chandler ask the question in the chat. But also, what we really need to be focusing on is bringing people together for more interdisciplinary exchange, more interprofessional exchange, to kind of have that translating over into decision-making spaces and into action on the ground. Thanks so much.
That's great. Thank you so much. So now we're going to move over to Danilo. So he's many of you will know him. So he's the program manager for AMR at WHO Euro. So he's been spearheading action to address AMR in the Euro region over the last couple of decades. And we had the pleasure of interviewing him to inform the development of this report. And he's going to talk about the WHO Euro roadmap on AMR, which we're really pleased to see includes considerations of the social determinants of health and how they influence AMR policy.
Thank you very much, Michael, and thank you very much for having me. And just first of all, I want to say that I really welcome this particular brief. It really I think it's at a very opportune time that we start discussing these things. I was just looking at my my other screen, and it seems to have frozen, unfortunately. I don't know if it's possible for you to share quickly. Yes, perfect. I don't want to go into too much detail because the roadmap itself is takes a little time to explain. But what I really want to zoom into is the topic of today's webinar. But just at a glance, we of course we have a vision where we mention both people, animals, and environment. So this already alludes to the first principle of the roadmap, is that we're looking at health through the One Health lens. But more importantly, so as also Victoria just mentioned, that we have a very people-centered approach, moving away from the focus on pathogens, and also linking closer to universal health coverage with a focus on equity and a more of a systems view. Now, the roadmap comes with three major outcomes. The first one more or less related to prevention, the second one related to control, and the third one related to treatment. And then basically what we've tried to do is not come up with another action plan on what needs to be done, but basically to find out what we already know. How can we move ahead with what we know and create more experience and a larger body of evidence? And basically we through very, very broad consultation, came up with 53 evidence-based interventions, which are organized in 5 action areas and 6 enabling areas. Now, the first 2 action areas are related to the control, so prevention and control, but I guess very closely related to today's topic, environment and social determinants. The second 2 areas are related to, the first one was prevention, the second one was control with stewardship and community awareness and enabling behaviors. And finally, the last action area is related to access to medicines and health products, which include diagnostics, of course. And then we have the enabling areas such as regulation, legislation, governance, surveillance, and laboratories. Strong focus on workforce, but also research, innovation, and digital technology. And if I could get somebody to click once, thank you very much. But what we really wanted to do is this to be a very practical instrument. So we turned the roadmap that you just saw before into the AMR compass. All the elements are still here. If you see in the middle there, we have the 4 principles. We have the 5 action areas, and there are sort of an envelope of these enabling areas around it. So what we really want to do with this compass is to use it as a tool to help countries assess their national capacity in these action areas and enabling areas, to find out what the gaps are, to prioritize among these gaps and really focus on that, set national targets, and then start addressing these evidence-based interventions that are related to that priority, and start the implementation. And finally, using the same process again to monitor and evaluate progress. And one thing that I may have forgotten to mention is that we really want this to link to all the other issues that are, or other instruments that are already out there. For example, there's a vaccination plan, there's a TB plan. One of the things specifically here, if you look at prevention and control, and I will not show the individual interventions, but it's very closely linked to water and sanitation and health. It's closely related to vaccination. If you look at environmental and social determinants, it is mentioning also the sort of the economic aspects of sorry, sort of the health workforce consequences, but also out-of-pocket payment, people that are having refugees and migrants access to the health system, etc. And I think this particular action area of environmental and social determinants is what's quite new. I think this is something that we haven't addressed very much in the AMR community, which has been very much again focused on pathogens and bug-drug combinations. So I'll leave it at that, and I think there may be some questions. It's very difficult not to go too much into detail. I wanted to spare you with those 2 slides with lots of details.
That's great. Thank you, Danilo. And we look forward to seeing implementation of the roadmap across the Euro region, and I'm sure many national policymakers will find that useful in adapting their national action plans. So we're going to move on to addressing some. So the chat has been very active, and we're really pleased with the amount of people that have joined today. So I'm going to hand over to Erica, who has been collating some of these questions now that will be put forward to the panel.
Yes, thank you very much, Michael. A very, very lively chat box, I'm pleased to say. Some big themes were coming out, and people have already jumped, some of the panelists have already jumped into the chat and sort of started answering those. But one of the questions that came up that I particularly like was addressed to the authors of this brief. What surprised you most when you were writing this and conducting the interviews? What were the things that surprised you most when you were gathering the evidence together? And then when we talk about AMR reduction programs and how they impact equity, who shoulders that burden? And I know Esmita said something in the chat, but maybe some of the other panelists would like to jump in on that one. And then thirdly, what can countries do to address the socioeconomic drivers and impacts of AMR globally? So back over to you.
So I can jump in and answer the first question related to the policy report. I think one of the things that surprised us the most is when we did the interviews for this project, lots of people said, oh, well, there's no evidence related to this. We don't know. There's lots of anecdotal evidence regarding what the socioeconomic drivers of AMR are. And actually, the first step is we need more evidence. But the truth is that there's a huge amount of evidence, and there's a huge amount of quantitative evidence that very clearly states that there are some particular population groups that disproportionately shoulder the health and economic burden of AMR. And also that there are other parts of policy that have been ignored, things like access to clean water and sanitation and hygiene, that may be potentially more effective at preventing infections than other more conventional policies that relate to infection prevention control. And actually, we need an integrated approach that uses both of these policies. So I think it was the breadth of evidence that we identified that was most surprising. So I think we need to move beyond just evidence generation now into incorporating these considerations into policy making and implementation.
So back to the panel. What do we, Tori, is there anything that you particularly wanted to pick out? Yeah.
Sure. I think the question from Claire about who's shouldering the burden of interventions is incredibly interesting. And I think that sits at a community level in terms of when we're asking community to behave differently, or certain population groups or people in certain roles and responsibilities, care roles, for example. I think that becomes a really important question. And public health does put a lot of burden, additional responsibilities and burdens on certain people, and that quite often is people in caring roles, which traditionally has been women, for example. But even a lot of the work that we've done in recent decades around community health workers is adding an additional burden to local women, to give them small amounts of training to run really fundamental aspects of primary healthcare that are relevant for AMR, such as vaccinations or early childhood information about what to do in the case of diarrheal support and things like this. And I think, a lot of our work, you can assume that there is going to be a similar, issue around equity or inequity in distribution of responsibilities for AMR. Honestly spoken, I haven't seen a lot of evidence around it. I think it's another example of where more investment is needed.
Thank you very much. Gunnar, how about you? Is there anything you would like to add, either on shouldering the burdens or on, for example, things that surprised you in the brief?
Yeah, absolutely. I wanted to jump off of what everyone's been saying, really. I think the thing that surprised me the most, I think when I initially approached the question, I thought, like I think most researchers approaching something, that there's some kind of unifying truth that you can find if you kind of look at the data sideways and squint a bit. And really, I think on this side of the report, I think I've just gotten gotten to learn that like the issue is a lot more complex than I really originally gave it credit for. So I really think that the complexity was, I was expecting it, but I was surprised at how sort of fractal it got to. And I think just for an example, the themes we pulled out earlier are really simplified versions of what the data does show. And for example, the interaction between gender and AMR, varies depending on the traditional roles that women take up in society. So it is all incredibly intersectional, and that's really reinforces the point that it does need to be very much context specific, rather than kind of saying, broad strokes that this socioeconomic factor is a risk to AMR. I think it is, as been said many times before, it's much more complex and more contextualized than that.
So Esmita, over to you. You wanted to jump in.
Excuse me. Thank you. So I just wanted to carry on just my answer to Claire, because I think Claire raises a very important question about who is shouldering the burden of AMR versus who's shouldering the interventions. And one of the things when we talk about socioeconomic and sociocultural differences and vulnerability or marginalization, I think it's also important, often when it comes to antibiotic resistance, we do tend to think of how to change the public's behaviors, which has its role, but it's important to identify how much governments and policymakers and industries also responsible. So if you take environmental pollution, for example, from pharmaceutical industry or from terrible release of effluent or sewage into the water, like we had, I give you two examples. We had the Cambridge-Oxford race in London this year, and the athletes got sick because there was raw sewage into the River Thames. And so our elite athletes got sick, and they couldn't do the race properly. But the population of London wasn't that much affected by the effluent in the river because of other systems that are in place. Whereas if the same thing happens in a village in a different country where the people rely on that river for their sustenance, it's a very different picture. And that is not the fault of either population. It is where policy and governments need to step up. So I always feel a little bit, and it speaks to, I think, Claire, we don't have an answer, but we need to be really clear about this when we look at the burden of intervention and who has to shoulder it. Really, how much are we responsible for that? And how much do we also have to put this back to governments about? And this speaks to environmental pollution, this speaks to climate. A lot of our exposure in antibiotic resistance bugs does also come from environment in different settings. And that's something we need to, when we talk about socioeconomic factors, we shouldn't just focus on the people, but also on governments that are looking after people who are, or have populations who are more vulnerable socioeconomically. I don't think I've articulated myself well enough. I'm sorry about that. But the point is, it's not just about the people changing their behaviors or people with socioeconomic differences having to change their ways. It's also how governments and policies need to support these populations through better policy and legislation, including the role of industry and pharma.
Thank you very much. Could we, Anthony, is there something you would like to add?
Yeah, I just very quickly, because I think most of the important points have been said, but I think it's something we don't give enough consideration towards. So one example would be agriculture, where there's a lot of pressure to reduce unnecessary use of antibiotics in agriculture. The way you mostly do that is by improving infection control and making these quite large upfront capital investments. And then the day-to-day cost of running the farm is not hugely changed by the fact that you're reducing the amount of antibiotics used. But it requires a certain level of funding and wealth to make those upfront investments. And too often that is not considered, or small farmers and farmers in poor countries find it much harder than farmers in wealthy farmers and large farms in high-income countries to make that kind of adaptation. The second thing I touched on briefly in my presentation is that often I don't think we make enough consideration for the fact that stewardship policies in general place a higher burden on more disenfranchised groups. And there's probably no way to fully alleviate that. But you see at the moment this huge contrast, particularly in low and particularly middle-income countries, where you've got these middle classes who are greatly overusing antibiotics, and then often poorer people who are struggling to afford 1 or 2 doses per day, or have to walk a very long way to get to their nearest pharmacy. And if you talk to people in high-income countries, they'll often be appalled at the idea that you can purchase antibiotics over the counter in low and middle-income countries. And you talk to policymakers in low-income countries, and they will often say, well, there's no doctors in this part of our country, or there are doctors too far away. So you've got the option of giving somebody an antibiotic, or you've got the option of not giving them an antibiotic because they'll not make it to a doctor. And often we don't confront kind of those hard trade-offs around stewardship, and we pretend that everyone getting a prescription before they get their drug is a reasonable ideal when it's not. And I think it is invariably the kind of poorest and disenfranchised rural groups, people who don't have, aren't confident enough to challenge authority, to who get left behind in these kind of situations.
Thank you very much. Thank you. So Tori wanted to make a quick point. So did Michael, and then we'll jump to Danilo for his input. So Tori, over to you.
I just wanted to follow up on that. I mean, these within country inequalities related to kind of urban and rural access and the cost of actually accessing health service and so forth are also incredibly relevant in high income countries. And that is actually quite underexplored in the literature, but there is some evidence. But a lot of AMR evidence around inequalities is in kind of urban inner city areas. But I'm doing some research at the moment, interviewing people in Germany and policymakers in Germany and Australia. And, rural access for health services is a huge issue in Australia. And that burden that we were talking about before is also a relevant question for health services, because people in rural areas, doctors in rural areas, then have to be the infectious disease specialist, the maternal child health specialist, the environmental health specialist, the anti-smoking and anti-obesity health promotion kind of person. A lot of that falls on these people where there are less health workforce. And we in public health kind of expect them to be able to pick up a whole range of these different portfolios, which are competing with each other for time and attention. And I think that's also an important consideration for equity and the implementability, the feasibility of actually taking an equity lens within AMR work.
I was just going to answer one of the questions around whether we looked at if healthcare financing arrangements had any relationship to drivers of AMR, and it was a recurring theme in some of the reviews that we identified, and specifically the need to picking up on what Anthony mentioned, the fact that in the situations where there is lack of access to formal healthcare, or there are financial barriers, it's not just financial barriers, it's also other barriers related to the location of healthcare services and educational levels around knowing when to access healthcare. And any barriers to accessing formal healthcare, we saw an association with increased unregulated access to antibiotics over the counter. So what we call for in the report is that the AMR agenda needs to be integrated with the policy initiatives related to universal coverage. So we need to see health system strengthening go hand in hand with AMR policy. So I hope I answered that question. So I'm going to pick up so I'll take Erica's role. So I'm going to pick up another question from the chat. So this is a fantastic question from Anand in the chat. So what would the panelists like to see come out of the UNGA high-level meeting on AMR declaration with regards to socioeconomic drivers of AMR? So would anyone like to jump in on this question?
Can I just say something on this? So in addition to the work we've done in this report, and I'm so grateful that we had the opportunity to contribute to this great work, the Lancet series is being published tomorrow, the Lancet series on AMR, and there is a whole series of recommendations in that which speaks to this report. And it is about contextualizing interventions and expectations when it comes to antimicrobial resistance. It is about making sure there is equitable access to affordable antibiotics, access to vaccination programs that are affordable and equitable, and access to water, hygiene, and sanitation in many parts of the world. These are still the interventions that are going to have the most returns if we're going to mitigate the threat of antimicrobial resistance. And alongside this, of course, we need multidisciplinary engagement on implementing antibiotic stewardship models that work for different settings, and seeing how we can bring the wider workforce, including pharmacists and nurses, which in many, many parts of the world still are not included in intervention as part of the solution. So I think those are the things that we need to focus on, and to have a concerted effort on delivering to these objectives in different settings.
I think there's what I would like the high-level meeting to come up with, and then there's what I hope is possible and would like to come up with. And I'm increasingly being reminded of the phrase that politics is the art of the possible. So things that I think are possible that would be good on this are, there is talk and a push to have a high-level panel, that independent panel on antibiotic resistance that generates evidence and shares advice and creates guidelines. I think that could be really useful on equity, and kind of everyone in this community has a role to play in making sure that evidence fed into that and generated for it includes these important questions on equity. The second thing I would like to see in the independent, come out of the high-level meeting is that more countries commit to sharing data on glass, and that should hopefully give us a much better understanding, at least at the national level, of where there are access problems and where there's high amounts of unnecessary use, and hopefully allow us to dig into what is happening kind of at a more granular level, and it's the more granular level where you see most of these disparities. And then finally, there needs to be a stronger push on national action plans and funding national action plans, and I think, again, generating evidence and pushing countries to include more stuff on equity in their national action plans is a really important way forward. And I think if we get all of those three things from here, that would be a huge win.
That's great, thank you, Anthony. So I think we're coming to the end of this fantastic launch event. So I'm gonna summarize some of kind of the key things that have been mentioned, although I think Esmita has just done a fantastic job of summarizing some of the key interventions, as well as Anthony. But so at the end of our report, we talk about 4 key policy areas. So we talk about stewardship, innovation, access, and prevention. And we talk about some of the considerations that are crucial to incorporating the socioeconomic drivers of AMR. So from a stewardship perspective, so we've talked about some of this today. It's about making sure that we conserve pre-existing and emerging antimicrobials and promote responsive use in ways that acknowledge the constraints and realities of different global contexts, and avoid inadvertent discrimination against particular populations. And for innovation, so innovation is not just about investment in new technologies and incentives, but we need to think about how we can design incentives that have conditions in place that promote equitable access to new and existing antibiotics in LMICs, but also within, as Anthony eloquently mentioned, it's not just an issue in LMICs. We see an equitable access across Europe and even within many high-income countries. And when we talk about access, we need to think about reducing barriers to accessing essential healthcare services and strengthening the procurement supply chain to make sure that we have consistent, sustainable supply of antibiotics when needed at the right place and at the right time. And talking about prevention, so yes, we do need investment in infection prevention controls in healthcare settings. We do need investment in biosecurity measures in agricultural settings, but we also need equitable access to clean water, sanitation, and hygiene infrastructure to prevent infection transmission and occurrence in the community. So bringing this all together, we hope to see more considerations of socioeconomic drivers in national action plans moving forward, and also discussed on the international policy agenda. But we just wanted to end on highlighting a further event that we have later in the week. So on Thursday, we also recently produced a policy brief for the Belgian presidency of the Council of the EU around overcoming implementation challenges for key evidence-based interventions in AMR. So this policy brief focuses on 12 interventions in the human, animal, and environmental health setting, and we map the operational, financial, and regulatory considerations for implementation for EU institutions and member states. So we would encourage you to also join that event on Thursday. So you can register through the link if you go to this QR code. And if you want to come back to this event and revisit some of our discussions, then there's a recording on YouTube, and you can share that through your social media and through your networks. So thanks again for joining. Thank you again to all the panelists as well, who have all contributed in some way to this report. And I would like to say goodbye to you all now.